Good morning, and thank you for the invitation to speak about this topic. I was asked to talk about intra-arterial chemotherapy, and I'm basically going to talk about hepatic artery chemotherapy, which I'll refer to as pump chemotherapy. And here we're basically talking about unresectable ICC. Pump chemotherapy is not new. This is a publication in 1984. A lot of people think this is a novel new treatment. It is not. It is quite old. And I want to give credit to two people because the data I'm about to show you has a lot to do with Dr. Nancy Kemeny and Dr. Bill Jarnigan, who have really championed these trials that I'm about to show you at our hospital. So classically, we treated colorectal liver metastases with pump chemotherapy, and the rationale was that the tumors were perfused by the artery, whereas the liver had a dual perfusion. We also knew we had drugs that we could give with a very high extraction rate in the liver. And colorectal cancer was often confined to the liver. And the real question that we developed over the last 15 years or so is whether this applies to ICC. We do know that there are drugs such as FUDR, which we use in the US, which has this incredibly high extraction rate by the liver, which essentially results in high-dose chemotherapy given to the liver without systemic exposure. I'm not going to talk a lot about this, but what I am talking about is not percutaneous intra-arterial access. This is a surgically implanted pump. Many of you know about this, where the liver is completely isolated surgically, just so we're clear about what kind of treatment we're discussing. This talk would not be complete without talking about the toxicity of this treatment, and I don't have enough time to go into this in great detail, but the toxicity is essentially one thing. It's biliary sclerosis. And although in older studies it was as high as 20%, it's much better today. There are patients who do require biliary stents. However, the majority of these, if caught early, will resolve with dose reduction or cessation and the use of steroids within the pump, something we've done for many years. We actually routinely give steroids whenever we treat someone with pump chemotherapy with FUDR based on a trial performed in the early 1990s, which showed that it decreased the rate of biliary toxicity. Most recently, for patients with unresectable disease, this is colorectal cancer, the rate of significant biliary sclerosis was 2%. And nobody really died from a biliary toxicity. Most of them ultimately end up dying of their disease. And it is probably most related to dosing rather than any other thing that we've looked for technically. So this is the one medical oncology slide I'll give. When you give this chemotherapy, you have to be very diligent and very detail-oriented about reducing the dose at any significant change in liver function tests. And if you don't do that, you'll run into a big problem. So it requires significant expertise about how to give this treatment. So let's talk about unresectable intrahepatic cholangiocarcinoma. As pointed out by Dr. Lang, most patients present with unresectable disease. However, the disease is very commonly limited to the liver. And I would argue that the treatment options are relatively limited. Ablative therapies are discussed, but as you've seen from countless examples, these are large tumors, multifocal. Thermal ablation is really not an option for these patients. Percutaneous intra-arterial therapies you just heard about. There are some promising data. There are not so promising data. I won't overlap with Dr. Salem. I'll just show one slide on that. There are limited studies on external beam radiation for large lesions, but very limited data. And systemic chemotherapy, while improving, really still has disappointing results. The systemic chemotherapy for years really didn't develop into much and essentially ended up with a standard of care as gemcitabine, but you can see the response rates are about 20 to 25%. The survival in general is less than 1 year. Most of you will be familiar with this trial, the ABC trial, which established gemcitabine and cisplatin as the new standard of care. However, it's important to realize while this improved things, it really didn't dramatically improve the long-term outcome. And I want you to remember these numbers: response rates of 25%, survival 1 year. And as you can see at the bottom of this curve, no long-term survivors. At about 2.5 years, all patients are dead of their disease. So what about embolic therapy? You just heard a lot from Dr. Salem, and I don't want to overlap with him too much, and I don't have time to go over every study like he did, but I think in general, if you look at all comers, not necessarily Y90, not necessarily any one thing, the median overall survival is about a year. Response rates range from 25 to 50%, but it depends on what you're using. And it's relatively uncommon to have long-term survivors unless they are downstage to resection, which was pointed out by Dr. Salem. Pump chemotherapy has been used for this in the past, so we are not the only center that done this. In fact, Pierre Clavien, when he was at Duke, did this, and a number of other people did it in the 1990s and 1980s. And these are extremely limited series, but you can see that there were some promising results. Patients were getting resected, there were significant response rates, and some long-term survival. However, this was abandoned back then, probably when pump chemotherapy was largely abandoned for colorectal cancer, which, as many of you know, is now seeing a resurgence. So we devised a study back in the early 2000s, where we decided to use pump chemotherapy for primary liver cancers. You'll notice that there are some HCC patients in these early series, which we really don't do much anymore, but focus on the intrahepatic cholangiocarcinoma patients. And this was pump chemotherapy with FUDR and nothing else. This was our initial study. The response rate was 50%. One patient was converted to resection, and that patient had a pathologic complete response. So we nearly doubled the systemic chemotherapy response rate. And I should comment, these were highly selected patients, multifocal or large and unresectable, but node negative and certainly no extrahepatic metastatic disease. And we started to get a sense of a few things. The 2-year survival was 60%, and that you can see initially that there were a few long-term survivors, which I'm going to come back to in the end. The next study we did was when bevacizumab first came out, and we said we have to combine this. There were theoretical advantages to drug delivery and the use of Avastin, and we thought this would be ideal. But unfortunately, this experiment did not work out. And this was one of 3 trials where we combined FUDR with Avastin, and what we basically found was that the biliary toxicity was significant. This is 22 patients, 3 required a biliary stent, and that's too high for us. So this trial was terminated early due to biliary toxicity, and we, in fact, never include bevacizumab with pump chemotherapy anymore because of other trials that have shown similar results. But in addition, we also did not see a dramatic improvement in response rates or outcomes, and so we don't think it was probably going to be very effective anyway. To me, this is probably the most important thing. We then updated, we had a number of patients with ICC treated with pump chemotherapy by this time, and we started to look at their long-term survival. And so this is 44 patients on these 2 trials, response rate 50%, stable disease about 50%. It is uncommon, very rare that patients progress early on with this treatment, an incredibly high disease control rate. A few patients were converted to resection, but this was not the only group of patients who were successful. Median survival, 29 months. And what I would like to focus on is that there were 5 5-year survivors. And we all now in our practices have patients like this. And there are patients who we think are cured of this disease, who are basically have pathologic complete responses and live many, many years with this, which is uncommon with other treatments. And this is a typical example of very large unresectable tumor, downstage to this, and never actually resected, and I suspect this tumor's dead because this patient is alive 6 years later with this tumor just sitting there off treatment. So these are the kind of maybe 10 to 15% of these patients, which is honestly very, very dramatic and probably as good as if you could even resect this large tumor. We then sort of compared this to systemic chemotherapy in the patients in our hospital. Obviously, many of them are, and you can see in this waterfall plot much higher response rates, much more dramatic response rates, over 30%. And you can see that pump chemotherapy is associated with this long-term survival that you don't really see with other treatments. This is not published data, but we've just finished our next trial, which was the next logical thing to do, which was to combine pump chemotherapy with systemic chemotherapy. You can do this because the chemo that we give into the liver stays in the liver, so those patients have no systemic exposure. This was a trial we performed with Washington University, 42 patients. We were a little more liberal in our inclusion criteria here. We included patients with lymph node metastases, unlike our earlier trials. And many of them had had prior therapy with systemic chemotherapy, typically, some of them percutaneous intra-arterial therapies. We used gemcitabine and oxaliplatin as our systemic agents and powered it for a PFS of 80% at 6 months. And we started to look at mutational analysis, and I'll point out some of this at the end. Again, unpublished data, but 42 patients, 40% prior chemotherapy, most had multifocal disease, and a high proportion had lymph node positive disease or very high risk disease, large tumors, of course. And what we've seen is very promising. 52% response rate, and again, the rest of the patients are largely controlled with stable disease. The median PFS was about a year, so patients are controlled for about a year, and certainly this met our endpoint of 80% PFS at 6 months. And the median overall survival is about 2 years, 3 years overall survival of 54%. And you can see again, these long-term survivors probably ultimately in the real long-term, 10 to 15% who are probably cured of their disease. We probably don't have enough of this to document this truly, but I really suspect this will be the case. What else have we learned from this? Because it really wasn't dramatically different from what we found with FUDR alone, but we started to look at some of the mutational analyses, and I would beg all of you to look at this, because people with IDH1 and 2 mutations, you can see small group of patients, but these patients do remarkably well. Look at this survival curve. This is unresectable intrahepatic cholangiocarcinoma patient. These patients have indolent, responsive disease and can live a very long time. And I think this will be the beginning of a very interesting stratification by molecular analysis, although this is all unpublished and still quite preliminary. But IDH1 seems to be a very helpful marker for this disease. We also learned how to stratify the risk of outcomes here. And it really gets into whether they've had prior chemotherapy and whether they're lymph node positive. Clearly, the best outcomes were those who had no prior chemo and lymph node negative. But once you start adding positive nodes or prior chemotherapy, the response rates, as you might expect, are lower. And although only 4 patients who come to us, extensive prior chemo, positive lymph nodes, so far we're not doing so well. So we are starting to get a view into how we should be selecting patients for this. So in summary, intrahepatic cholangiocarcinoma, as you've seen, is often, even when unresectable, is often a liver-only or liver-dominant disease. So I think regional approaches make a lot of sense for this disease. With FUDR alone through the pump, we have very high response rates of 50% and very promising long-term survival. And I do suspect a small group of patients are actually cured by this disease, by this treatment. Unfortunately, Avastin, never to be used with pump chemotherapy due to high rates of biliary toxicity. And I think what we've seen some promising outcomes with systemic chemotherapy combined with FUDR, a lot like we do with for colorectal cancer. Response rates are similar, and I still think it's a little too early to say much about the long-term outcomes. And we are starting to learn about stratification and prognostication and how to select patients, and also a little bit about a molecular analysis and how to select patients for this. So what's the future for pump chemotherapy? I think there's a few things. I think adjuvant therapy is something we can do. We actually tried to do this trial, but we couldn't quite accrue to this. This will require a multi-center trial, but I think since the intrahepatic recurrence rates are so high, the model from colorectal cancer that we've done for 30 years of adjuvant pump chemotherapy is going to make sense, but it needs to be tested in a trial. I do think even treating patients with multifocal disease and using adjuvant therapy is a reasonable strategy, but that needs to be studied. And I also, obviously, I think as we will continue to study this, we'll continue to study this with novel combinations with systemic therapies, and I think that will be the promising thing for the future. Thank you very much.
Michael, thank you very much for the nice data. Have you seen any correlation between the tumor load and the outcome after perfusion? It means if you have a single tumor comparison to multiple tumors in both sides?
Yeah, that hasn't been the issue. For us, it's mostly about the lymph node positive, because when we put the pump in, we sample the lymph nodes. We don't do a complete lymphadenectomy, but we do a sampling. And the lymph node positive patients really is the biggest prognostication. And I think we're going to see mutational analysis is going to help us very much as well.
Good. Are there any questions from the floor?
Just a short question. You have shown a very good, a high response rate of 50%, and you have shown a case with a very good response. How do you judge the role of surgery after such a good response?
It's interesting. We resect about 5 to 10% of these patients. Multifocal disease, we typically won't reoperate on, even with a dramatic response. But as I showed you, the large tumor that responds, a percentage of those patients we operate on, they don't all do great. I think we have some of our long-term survivors are patients who've just had pump chemotherapy alone. So we struggle sometimes with whether to operate on them at all, because although Dr. Lang showed some amazing operations, the outcome for all those is not so great. You expose them to some significant risk of morbidity and even postoperative mortality. And we're starting to see that some of these dramatic responses are durable and last years and may, in fact, cure these patients. So we struggle with that. But we operate on about 10% of them, and it's not the surgery necessarily that changes the outcome. I think it's the chemotherapy. So.
Okay, thank you.
Michael, one other question. Do you have experience with isolated liver perfusion, with chemosaturation technique, with melphalan?
We don't have any experience with this, but I think that the concept is the same. High-dose chemotherapy to the liver, isolated from the rest of the circulation. Right. We accomplish that biochemically. This drug does it for us, if you don't understand what I mean. So when you infuse it, they get local high-dose chemotherapy. So we have not done those perfusions because biochemically we can isolate the liver this way with this drug.
Okay.
That's the theory.
Thanks.